to our sharing practice session as part of the Greener Palliative Care Award. We have got hopefully 3 speakers today who are going to talk about a variety of projects that they have undertaken with regards to medicines and delivery of medicines, use of medicines, and how we can reduce the impact of that on the environment. So that's really exciting. It's a big topic that comes up when we're speaking to our Greener Palliative Care Award pilot sites. So it's really exciting to hear what you've all been up to and to share that. What we will hopefully do is have 3 speakers, all of who have got about 15 minutes to talk, and that should leave us lots of lovely time for questions and thoughts and inspiring ideas and actions at the end. So please be thinking about your questions as we go along. So without any further ado, we will hand over to our first speaker, who's going to be Dr. Saskia Dormant from Forest Home Hospice, which is an NHS hospice down in Dorset and is indeed one of our pilot sites. So Saskia, the floor is yours.
It's great to be here. Great to see people, and thanks for the invitation, Kate. So this is quite a small project, really, but kind of has opened up lots of conversation, discussions, and some change in practice. So really glad to be sharing with you today. So we're talking about subcutaneous injections. As Kate said, I'm one of the consultants based at Forest Home Hospice, which is an NHS hospice. We've got 11 inpatient beds and then community team, hospital team, complementary therapies and counselling and so on. So subcutaneous injections, as I'm sure for any of you based in hospice, is something that we do most days of the week, and worldwide there's 16 billion injections in healthcare, so it's huge. It's one of those things that I think it's almost hidden in plain sight as something where we're so used to doing it that we sometimes forget to reconsider how we might do it. So just thinking about this topic, we kind of looked at what equipment we already use, what does the life cycle look like from each of the things we use, and how can we reduce what we use. These are just sort of pictures from the internet, from Unsplash. Interestingly, when I was looking on the internet, almost all of the subcutaneous injection photos showed people wearing gloves. So we'll come back to that in a moment. This just looks at from No Harm Healthcare, or Healthcare Without Harm. This is a study that was done thinking about reducing plasma. I'm just going to change this to slideshow, actually, sorry. Current slide. This is hopefully you can see that a bit more clearly, a study that looked at several different hospitals. In one hospital in particular, they looked at the amount of plastic waste. This is looking at the top 6 items in healthcare that combined contribute to over 60% of the plastic waste in hospitals. So disposable gloves is a big part of that, nearly 18%. Syringes, which we're talking about today, are about 8%. You can see the other things there. I suppose in hospice we don't tend to use intravenous lines so much, but we do sometimes. Some disposable protective clothing, but yeah, gloves and syringes are the main things from our point of view. So I'll just go on to the next slide. This is a rather blurry picture of Forest Home. It's pretty small, but yeah, as I say, 11 beds. And this is the kind of things that the equipment that we would normally use when we're given a subcutaneous injection. So if people are attending to need subcutaneous injections rather than just a one-off, we would tend to put in a subcutaneous cannula, so one of these safety intima, which looks a bit like this when it's in place. Gloves, question mark. Certainly they were in use a lot before this project. And this is a tray showing what nurses were taking to a patient. Haven't got the actual drug in there, but there's the syringe to give the injection, syringe to give a flush, and a bung as well as the needle and the flush. And then one of the team who really led on this, I would say, is one of the nurses, one of the senior staff nurses, called Sarah. She couldn't be with us today, but in a moment we'll show a video of the changes that we've been making. So just thinking about the life cycle of each of those things, the plastics in there. So gloves developed from fossil fuels. So in terms of plastic used in healthcare, over 98% of it is developed from fossil fuels. I'm sure lots of people on the call will already be aware. There's then the kind of energy and chemicals that go into refining and manufacturing. There's use of product and there's product disposal, which in healthcare, much of it is incinerated. So the gloves can't be recycled. The syringes and the needles, etc., would mainly go into incineration. Again, looking online, when I was looking at kind of life cycles of these products, a lot of the images that were online a lot of them actually showed a circle, quite misleadingly, I think, because essentially almost all of it does go into incineration, and this kind of linear life cycle is actually much more the norm. And there's, in terms of the health impacts, there's kind of health impacts at every single stage of that life cycle, whether it's exposure to kind of toxic chemicals, both at these stages, but also at the incineration stage. There's all sorts of things released into the atmosphere when syringes and plastics, etc., are incinerated. So when we're thinking about how can we reduce the use of plastics and use of equipment and syringe in subcutaneous injections, it's actually much preferable to rethink and rethink what we're doing and reduce the need, rather than it is to recycle. Overall, globally, less than 10% of plastic is recycled, even though a lot of it could be. So in this, we're looking at mainly at reducing what we use. And this is a little very homemade video I made on my phone of Sarah Webb, who's one of the senior staff nurses, talking about the changes.
A lot of people have been using one syringe for the medication and one syringe for the saline flush, but actually a few members of staff have always just used one. So actually a lot of people agree that actually just using the one syringe, so you give the medication, then you draw up the flush, and then you give the medication using the same syringe, is absolutely fine. There's no infection control problem. You're not giving them too much drugs. You're literally just giving the flush, and it saves taking 2 syringes to a patient instead of 1. You've gone from 40 syringes to 20 in a day. So.
Just go on to the next slide when I can work out how to do that. There we go. So yeah, so that's the before, and that's the equipment used after. And then Sarah's just taken a picture of how much we would get through in a typical kind of 3 days before this change and then after this change. So it sounds like a really, really small thing, but actually that sort of change over a month, over a year, over the years can actually really add up. So let's go on to the next slide. And it's one of the things we've been sort of, this is a poster that we did in the eco group, so just as a way to kind of help share it with others in the team and others across the hospital as well. The hospital's got around 9,500 employees, and we're just a small part of it, but we've been kind of trying to share what we're doing and learning from others as well. In terms of the gloves, so again, a lot of you will be aware of the Gloves Off campaign, which has run over some years. And we revisited that at the hospital last year. There was another big push in kind of second phase, phase 2 of that. So as part of this big University Hospitals Dorset Trust, we're kind of involved in some of the initiatives as well. So that was a trust-wide adoption of that initiative as well. But I think there's still quite a bit of room for us to improve on that. I think it's made some difference. There was quite a lot of talk about how you could reduce the amount of gloves, and that would enable patient, skin to skin contact and compassionate care, and that people to think twice about when they need gloves. But I think in things like giving injection, I don't think that message got through as much as it could have done, perhaps. So that's something that we're starting to revisit it again and see what else we could do to help more of the staff to feel more confident about that change. I think with both with the syringes and with the gloves, I think there's a kind of core of people who perhaps were starting to use it and then had the confidence that this become part of their practice. I think there are still some members of staff, just even from chatting to people more recently, some staff, particularly perhaps the ones who are newer in practice, would much rather take all that they need to the patient and not have to worry about drawing up flushes and things like that when they're at the patient's bedside. So the practice, I would say, it's still, there is some variation in it, but this kind of change, I think, can just help to build the both awareness and sort of social acceptability of a change in practice, which has been helpful. In terms of our next step, so the Gloves Off campaign again, we're having a session with a pharmacist next month, a kind of lunch and learn, which is looking at various different things to do with pharmacy medications and bringing in kind of sustainability in different areas into that. And also we'll be discussing with community colleagues as well, because I think some of these practices just we need to embed them where we are and also kind of help to spread that ripple effect to other settings too. So those are our next steps. And just one more slide, which was about kind of recycling plastic syringes. So this was something that's in the Lancet this week about why are plastic syringes not being recycled. If they're mainly made of polypropylene and polyethylene, which should be, theoretically, they should be recyclable, but because they're often viewed as, or healthcare plastics are often viewed as high risk, they don't get into the recycling streams. But this article gives some really encouraging, I'd say, examples of places in which plastics used in healthcare are starting to be recycled much more. So this example from a teaching hospital in Nepal, complete kind of rehauling of their waste management system, and as part of that, the syringes that they use, they use needle cutters or to remove the needle from after they've been used, separate out the syringes, they're autoclaved, and then they can be handled in waste and recycling strategies. So in doing that, they've not only managed to have a much safer system where many fewer of the staff have needle stick injuries, but also they've been able to significantly safer waste management practices and also get some income stream as well from the recycled waste, because syringes are quite good quality plastic, so they actually have a reasonable potential for this hospital kind of fund. They were able to sell on that plastic waste to be recycled, and that was one of their income streams. So I think that was it. Oh, this is just a reminder of what syringes used to look like. I think that's rather beautiful, and there's a lovely web page on the National Museum of Scotland which talks about the history of them. I certainly remember 30 years ago when I was a medical student on the surgical attachment, the rather possibly approaching retirement surgeon at the time in one of the district hospitals was using metal and glass syringes and sending them to autoclave, and that was his practice. That was back in the 90s. So it's interesting how practice kind of changes over the years. But yeah, that's me. I'll just stop.
Thank you,
Thank you,
Cecily.
Kate.
That was excellent. So just a quick update. So we have had apologies from Julia, who was meant to be our second speaker. She'd already sent me her slides. So what I might do is quickly just whiz through them, because there's some quite interesting stuff there and it might prompt a bit of discussion. But as that gives us a bit more time, Saskia, if it's okay with you, I thought we might see if we've got questions on that project now rather than saving them for the end. So
yeah, of course.
Yeah, so okay, great, thank you.
Questions and suggestions as well, because I'm
okay, well, I will kick off while oh no, I've got a hand up. Great, then I can stop talking. Kay, please go ahead if you've got a question.
Sorry, I missed the very start of your presentation. One is, how long have you been doing this, and have you had any problems with changeover of staff? So if there's, we often find in the hospital, I work in Sheffield, we've got the 18-bedded Macmillan unit, and we look after the hospital as well. But if we do any of these initiatives while we're doing the thing, until you get your poster done and you've presented it somewhere, and then we change SHOs or we change the nurse in charge or something, and it just tails off. And I think one of the big problems we have with sustainability things is we have a big push and woohoo, and then you come and you think, actually, and 6 months later it's, oh well, actually it's easier if we take 2 syringes, and and somebody comes back from maternity leave and they didn't know about it, and they have more of an influence than the people who were doing it when they were off. So how do you manage the keeping it to the forefront?
I think I absolutely kind of can empathize with that, and I think that's part of the issue where it hasn't, it's not like this practice is across all staff all the time for now and evermore. I think we have gone from it just being 1 or 2 people to now being a kind of most of the team, but it's not all of the team. I think we have been doing it since last year, and there has been stability in terms of the senior leadership over that time, which is good. And I think another helpful factor has been the sort of buy-in from a couple of our more senior nurses that kind of across the whole service are really, really into environmental impact, sustainability, etc. So they have helped to keep it at the top of, one of the top things in the agenda. And the other thing, from a trust point of view, so as I said, it's a big organisation, but there are kind of 5 key strategic themes, kind of key areas that run right through from ward to board, kind of, and we've been told these are the ones that are going to stay for the next 10, 20 years. One of those is sustainability. So that really helps as well. So you can kind of, this isn't just a kind of just somebody's idea. This is like part of how the trust is trying to work. This, do you know what I mean? That senior leadership at that level, I think that really helps, and the consistency that it is a priority. And I think just chatting with some of the team, some people are saying, oh yeah, it helps to save the trust money, and yes, obviously if you use fewer gloves, if you use fewer syringes, they're going to save money, but it feels like a bit of a win-win really in that term. Use less, cost less, and it's fine.
Yeah. Cool. Thank you. And I can see Ruth has her hand up.
Hi. Yeah, thank you. It's really interesting. I wonder, so you've primarily focused on using less, is that right? Have you explored recycling? Because I think you talked about that at the end, but was that a paper you found rather than anything in your practice?
Yeah,
right,
no, that was in preparing for this talk. I thought I would. Why don't we use so much plastic in healthcare? How much of it is recycled or can be recycled? So that was just something I found through preparing for this. But I think it's interesting. But I think in terms of the waste hierarchy, what makes most sense to do is to kind of reduce how much we use rather than try and recycle just what we're already using. But I think in healthcare, we're always going to be having injections, aren't we? We're not going to get away from plastic altogether. But
I was just wondering about the practicalities of recycling things that have come out of a sort of a healthcare setting. But maybe
and I think but there might be differences in terms of because when I chatted to one of the pharmacists who's really very much into, she was part of the Pharmacy Declares, very, very into kind of environmental impacts and so on. And she was saying because the waste disposal processes don't have like for water, there isn't a process in there that gets rid of medication. So if we've got syringes that have had medication, they need to go in the sharp bin to be incinerated, or that needs to happen rather than to wash them out and things down the sink. But there are also things, like if we use a saline syringe, that's salt water.
That would
But salt water that hasn't been in contact with anyone's bodily fluids is, to my mind, that feels like that should be absolutely possible to recycle. But I haven't explored that locally recently on the back of that paper to say to try and progress it at all. I'd be interested if anyone on the call has.
Thank you.
I'm just going to ask a question to the group before we move on to Kate's talk, which is maybe we can just do a hands up. How many of you think the usual practice where you work is to wear gloves for subcut injections? Stick your hand up if you think your team do wear gloves for subcut injections. Yeah, lots of hands going up. Yeah, I think that's, even though it's clear if any of you looked at the Gloves Off campaigns, which I know Great Ormond Street kind of spearheaded, but is like a national thing now as well, Royal College of Nursing, etc., etc. It's very clear that we don't need to use gloves for subcut injections, but I think getting that buy-in and the infection control team on board and all of that. And I was really struck by, Saskia, you said something about sort of sustaining this was a function of experience, confidence, and social acceptability. I thought that really captured it, having that experienced nurse that everybody looks to, that the people coming back from mat leave or the newly qualified nurses go, well, she does it like this, so it must be okay. And just the power of that. Fascinating. Okay, thank you. So if Kate is ready, we will move on. So our next speaker is Dr. Kate Seaton-Jones, who's a consultant from Phyllis Tuckwell Hospice, who are down in Farnham, and they are also one of our pilot sites. And she is going to talk to us about de-prescribing. So Kate, the floor is yours.
Lovely. I'm just going to pull up my presentation and share screen. Give me 2 ticks. Can you see it?
Yeah, but it's not on the first slide. Probably because
Okay.
you were checking it earlier.
Hang on. Let me just get back. Which way am I going? Yeah, there we go. In Violent Pink it is. It's a great pleasure to be able to speak today. Now, as I'm looking at my screen, because I'm on a single laptop, I won't be able to see if anyone puts their hands up, so you'll have to interject. But I do welcome questions as we go through. Now, as I present this, don't think I've got it cracked, because I haven't. I'm just going to share you how far I've got with de-prescribing. This is a talk I've given a number of times, so it's got learning objectives. Not that I'm expecting anybody to learn anything today, but I was going to talk through the trouble with evidence-based medicine, discussion of the tools, and a generic but palliative approach to be stopping medicines. I have a longer version of this talk, which has my hit list of medications to stop, but I'm afraid I don't think we'll have time for that today. So what's the problem? Well, it's, oops, sorry, beg your pardon. It's partly evidence-based medicine, and my machine's got too hot. It's skipping slides. Sorry. Evidence-based medicine is often around single disease frameworks. So we have nice guidance for cardiovascular disease, nice guidance for neuropathic pain, nice guidance for the epilepsies. But how do you do all of that all together? There was only one nice guidance that I'm aware of that covered all conditions, which was the nice guidance on multimorbidity, which is hardly known about at all. So these single disease frameworks do not suit a lot of patients. They don't suit the frail, they don't suit the multimorbid, and they certainly don't suit palliative care. And because we've got an aging population, we're going to have more frail patients, more with multimorbidity. And that leads to patients being on 5 or more medicines at any one point. Oh, I'm sorry, I'm having a real problem with my computer. I'm sorry, I'm skipping around the slides. So there's lots of tools out there, and I was just going to briefly talk about 4 generic tools. Sorry, not generic tools, non-palliative care tools, and then go on to talk about what a way to do it in palliative care. So those are the 4 listed at the top, and I'll come to each of them in turn. There is the ONC-PAL de-prescribing guideline, but unfortunately it's behind a paywall, therefore not readily accessible, and it hasn't really picked up traction in specialist palliative care either. So let's have a look at each of the four that I've listed. So first we've got the beers list. It was originally created in 1991, and I put the QR code up there in case anybody's really interested in looking at it in more detail. It's endorsed by the American Geriatric Society. So as you can imagine, it's created for an American audience, and it aims to reduce potential inappropriate medication in older adults. And by that, they mean over 65s who are ambulatory in an acute institution, but not in a hospice or end-of-life care setting. So that automatically rules out palliative care just about. And I'll show you how it appears. I'll give you an example of how it appears. It looks at the side effects in the elderly due to the physiological changes of aging. And a lot of the drugs in this guideline are not in use in the UK, so that's not brilliant. And also a lot of our existing guidelines would steer our practice in line with this tool anyway. So we just stuck to the guidelines we've got, we would be fine. So here's an example. So we've got, I think that's Septrin, and it talks about cautions with other drugs and the risk of high calcium, etc. So it doesn't say stop this in this circumstance. So let's go on to the next one. This is a more UK tool. This is a stop screening tool, stop start. Explicit criteria that facilitate medication reviews in the multi-morbid older people in clinical settings. It was they got a group of people around a table and came up with a consensus methodology. And it was European doctors, pharmacists, pharmacologists, and primary care physicians. So they had 114 criteria, 80 to stop drugs and 34 about starting drugs. And it was about making the drug, that person's drug therapy appropriate to the patient. And they're grouped into the same kind of chapter headings that the BNF are, say, cardiovascular, central nervous system. It's all very nice, consistent, as in nice guidance consistent, which is great. So this is how it looks. Here we've got some information on anticoagulants and antiplatelets, and it tells you when to stop them and when to start them, and it references the nice guidance. So that's kind of useful, but not entirely palliative. Then we've got the impact tool, which stands for Improving Medicines and Polypharmacy Appropriateness Clinical Tool. It links to, I don't know how we say it, Prescrip resources, and you need a login for that, which I'm afraid I don't have. Thankfully, unlike the other tools, it's useful for all ages. Again, it's grouped by physiological system, and it rates the clinical risk and de-prescribing priority on a kind of high, medium and low. It links well with NICE stop start guideline, which you've just seen. And yeah, there's QR code. So let's have a look how it appears. It's really wordy and it's quite a long document, and you can see the final two columns talks about the risk and the priority for stopping them. Okay, this one, No Tears, it's an acronym, and it's picking up on many of the themes the other tools have looked at. It was devised by a GP in Wales back in 2004, and it's kind of really a list of thoughtful questions rather than a list of medications, and it references many of the other tools that are out there. So none of them perfectly fit our situation of palliative care. So this is what the questions that I use to help me de-prescribe. So first of all, very key is what matters to the patient. I also consider about what the therapeutic aim is. Are they truly palliative, or are they curative? Are they in a chronic disease management phase, or are we trying to modify the disease? Hopefully, most of our patients will be under the first category, palliative, but you might want to consider this. So for example, if you've got an early palliative care patient, they still might be having chronic disease management for their type 2 diabetes. Then to think, is this drug still needed, still indicated? Has the condition changed since they've become palliative? So is the drug still needed? A lot of people get placed on PPIs and then it just gets continued, and not everybody needs their PPI ongoing. Has the condition changed? Perhaps they're on a dementia drug and the dementia might have worsened. Some of those drugs are only licensed for mild to moderate dementia, and in advanced dementia, some of the drugs should be stopped. Can the patient continue to benefit? Things like Zopiclone, are they still getting a decent night's sleep with Zopiclone, or actually have they got used to it and they need to be weaned off it? Has the evidence and guidelines changed? Not everything stands still. And are we using a drug to treat a problem that we have caused? For example, PPIs and steroids. Actually, have they come off those steroids and now the PPI should have been stopped? And what are the ethical issues about withholding this part of care, e.g. antibiotics? Would discontinuation, particularly abruptly, cause some problems? So those are therapies like baclofen and benzodiazepines. So all of that's swirling around my head as I think about the drugs. And then as I'm looking at the drug chart, I'm categorizing the drugs that the patient's on into various groups. So drugs with a temporary indication, where I'm going to be wanting to get rid of them soon, very soon, as soon as that indication's expired. I'm going to be wanting to get rid of high-risk drugs if I can, for patient safety reasons. Preventative drugs. Then I've got a group of disease-modifying drugs, replacements, and the last group are the symptom management drugs. And I'm thinking more beyond analgesics and antiemetics. I'm also thinking anti-epileptics, Parkinson's meds, diuretics in heart failure, and drugs to control heart rate. Those all help reduce symptoms, and those are the ones we're going to hang on to. So then I get this order. So this is my order of stopping. So get rid of the preventative or no indication drugs on becoming when the patient is deemed palliative. Those with a temporary indication, stop them at the earliest opportunity. The disease management, well, yes, they're also going to go early, but often in discussion with the patient. And those symptom managements, I'm going to keep as long as possible, and I probably need to change the route as the patient gets sicker. And the replacements, like my type 1 diabetes, my insulin for the type 1 diabetes, they have to continue right through to the end of life. So at the end of my de-prescribing, I'm hoping it fits with the patient's priorities, and that drugs that are there that control symptoms but not numbers, and the drugs work over a matter of days, not over years. And they lessen, and my whole procedure of de-prescribing lessens the environmental impact. And I put in brackets because that isn't really the theme of this talk, but they're actually easy for the patient to take. Otherwise, they're never going to take them. So I won't go into my hit list. I'm going to stop sharing and open up for questions.
Lovely, thank you, Kate. Oh, and I've got a hand up already. I like this. Okay, Saskia, do you want to go first?
Thank you. Thanks, Kate. I was wondering if you ever, because it all makes really good sense. I love the way that in one of your last slides you kind of talked about the order in which you approach this. I wondered if, from a patient perspective, whether you get any kind of pushback or challenge, or how patients find it from your point of view.
So it really depends at which point you are approaching the patients to stop their drugs. If their prognosis is really short, it's a no-brainer. They're delighted to have less tablets to take. But early on in that palliative journey, where particularly with, say, your type 2 diabetes meds, where they've been utterly wedded to them for many years, it's quite a wrench, and you have to work hard and gently as well at the same time. Work hard with the patient in the way you're communicating, and communicate sensitively and gently about why they could perhaps stop some of their drugs. But I don't attempt to complete it all in the first sitting. If they're really reluctant to come off their drugs, let's give them time to think it through. It is a partnership after all.
Yeah, thank you. And definitely a process, isn't it? Not a one-stop.
Yeah.
Yeah. Melinda. Oh,
sorry, struggling to come off mute there. Hi. Sorry, my Teams is joining me on a different version of my Teams. So I'm actually a consultant pharmacist in Oxford. So apologies. I do also work for Eleanor Hospice a little bit as well. Just thinking about the de-prescribing tools that you just mentioned, Kate. Have you ever used the stop frail version rather than stop start?
No, I haven't. I didn't know about the stop frail one.
Yeah.
Say more.
So this is one that we decided that we would use a few years ago in Oxford as part of a research project we were doing at the time, actually. So stop frail builds on stop start, but is more geared towards our kind of palliative patients. So there's a lot less starting of medicine. So there's less of that switching, because I appreciate stop start stops 80 and starts, was it 20 something? Stop frail doesn't really suggest starting any. What it actually does is go through quite systematically and say, if your patient, you know, broadly fits within this category, what you can do is run through, and it does very much the same as going through like the different body systems. So it's laid out very much the same as a BNF. So it starts and runs through all your different systems. But actually what's great is like the first few questions in stop frail are, is the patient actually routinely taking this medicine? Because if they're not, just stop it, because it's actually not helpful. Regardless of what that medicine is, it's not helpful if they're not taking it. And is it things like vitamins and things like that? Because actually in reality, how much help are they for our patients? If they need vitamins because they're, you know, refeeding or something like that, then they'll be seen by a dietitian and had them actually recommended appropriately. So it's all of those kind of things. So it's worth just taking a look, because I actually find it's quite nice to use. And what I did when we brought it into use in Oxford was I just went through and added some examples of the drugs, because it kind of went through, you know, it would say it was an angiotensin receptor blocker or whatever, and it wouldn't actually give you the name of the drugs, which I thought was slightly less helpful when we wanted people to use it quite widely. But it's worth having a look, and you can get quite quick with it.
So our next step at my hospice is to write an internal guideline that we will get our juniors, that resident doctors that rotate into us, to read, and that all of us consultants are signed up and our pharmacists are signed up to it, and that we will teach our non-medical prescribers it, or encourage our GPs and say, look, so that we're all on the same page.
Yeah, absolutely. But yeah,
great.
take a look at it. It might be helpful.
Thank you.
Okay.
Me again. I don't know if anybody's come across the De-prescribing in Palliative Cancer Care, a Swedish paper. It came out in 2022. It's a lovely, very small table that I don't know if you can see it.
Try holding it up. You never know.
Teensy little table that basically says, you know, if they've got less than a year left to live, get rid of these ones. If they've got less than 3 months, they've got less than a month, if they've got days, you know, get rid of them. Makes it quite easy. I mean, one of the things that we found, I think, with de-prescribing in geriatrics, because they talk about the potentially inappropriate medications, and the medications that cause more harm than benefit, one of the things that we had struggled with in Sheffield was, how do we start this conversation with patients about, you know, should you stop the medication, or, you know, because, you know, you don't need your blood pressure medicines anymore because you're not going to be alive. You know, that we were worried about how we would have that conversation. But actually, you know, if you can say to them, you know, there's guidance out that says if your blood pressure is this tablet can be doing you more harm than good, and it's shown to, you know, cause older people to fall and, you know, end up with broken hips and things. So, you know, what we were trying to prevent before is not something that we want to prevent now if it's going to cause you more harm than good. And there's polypharmacy guidance, I think from NHS Lanarkshire from 2018 that's got actual cut-offs for blood sugars and hemoglobin A1Cs and things, which is, you know, you're just like, oh, well, if I've got a number and I can say, well, your blood pressure's, you know, 100 systolic at best because you've lost 5 stone, maybe you know, this is not needed anymore. So, and have you done any sums of, you know, what you've de-prescribed, or, you know, how, because we've actually looked at, we had one of our registrars did it for us, you know, educating people on de-prescribing, because in the hostel support team we go out into the hostel, so we're seeing people at a much earlier stage than you would in a hospice, and we've looked at what things we're stopping. We know which ones are the most common, and then, you know, over a period of time, you can say, well, if I've stopped 3 medications in one person, yes, they might just be cheap ones, but actually, if you save that in, you know, all the people that we see, or, you know, half of the people we see, you would save a lot of money and a lot of environmental impact. We've just sent the numbers to somebody to help us with the CO2 reduction as well. So it makes, I mean, we looked at just paracetamol, stopping, you know, regular paracetamol with a strong opiate, because there's, you know, evidence that it doesn't add to a strong opiate, and we, you know, took the paracetamol off everybody that came into our ward. If they didn't think it was helping, if they thought it was helping, we kept it. If it didn't work, or if they weren't quite sure, we just put it on the PRN side and said, see how you go. Nobody had it reinstated. There was about 2 doses of paracetamol taken in over a month, and those were sort of for headaches, so they didn't want Oromorph. And we saved enough CO2 for a return journey from Edinburgh down to London and back up again in an average family-sized car. So there are, once you get the numbers, you can then put the environmental impact on and the savings, and it just takes off a life on its own. Everybody gets all excited about it, P&E savings, and, you know, then, yeah, the pharmacists are like, oh, can we do that too?
So, Kate, can I ask you a quick favour? Could you put a link to that Swedish paper and the Lanarkshire, was it? Lancashire? I've forgotten.
Lanarkshire.
Guidelines. Yeah, could you put that in the chat? That'd be really helpful.
I can try.
Thank you. Or email it to me later if you can't.
Yeah.
But didn't find it quickly enough to put in the chat. And I think your SPR Victoria, was it Dr. Cox, Victoria?
Yes.
She was here, but I think she's disappeared. Because I'm sorry, Christine, I'm not ignoring your hand up. She had a different phrase that she used, because we've heard
my barbs.
My barbs. Can you tell us what that stood for? Because I thought that was an interesting. If not,
medication of indeterminate benefit. And
wait, I've got it here. Medications of increased burden and reduced benefit.
That's it. I wasn't part of the developing that, but, you know, we now talk about my barbs, you know, in here, rather than just general de-prescribing. And
and I might open that discussion about language up in a minute, but Christine's been very patient. Now, Christine comes from a children's hospice, which is one of our pilot sites, so I imagine she's going to bring a different perspective. Let's see.
Yeah, I mean, I was just going to ask if, I guess, you came across any guidelines that are for pediatrics, because I got excited when you said the impact is all ages, but it's not really. It doesn't mention pediatrics anywhere in the 87 pages.
It's probably all
for child, adolescent.
Yeah,
it's not for children. So I guess just if you came across any guidelines that do include anyone under the age of 18.
Not that I look for them specifically. I'm afraid I'm such an adult physician, so I didn't hunt hard, and I certainly I can't remember coming across any.
Yeah, I think for a few reasons, I think pediatrics is a lot harder for this kind of space, because it isn't patients making the decisions in 90% of the situation. It's parents who want to keep everything going. And I find it really hard, and it would be great if there was a guideline for us, but I haven't come across any ever.
Having said that, I thought
surely a lot of the medications that we're stopping are preventative older people disease medications.
Yeah, our kids are, I guess, on a different slew, but have more polypharmacy than adults do.
Yeah.
I actually thought, Christine, while Kate was talking about the the way she categorized the drugs, that kind of approach I could see working. So, you know, what's for a
That's what I
short-term
wondered.
indication? Yeah, what's long-term prevention? I could see that there's a guideline maybe in there about how you approach those conversations rather than
Yeah, I think it's also about confidence in pediatrics. Like a lot of people are not confident to stop medications and that they end up just adding them. Because I think we've done some stuff about polypharmacy. I forget how many children in pediatrics were over 10 to 20 medications regularly.
Yeah.
It's a lot. Because people just add and add and add and add, and they never stop. and our trajectory is not as close to know who's 12 months, 3 months away from death. So I find it really hard. But Ruth
And
might have
Christine-
something nice to say. She's from peds as well.
Yeah. And Christine, presumably it's a similar, the multi-morbidity model and the kind of complex chronic disability model that you see is a similar, there's single disease guideline, but there isn't one for.
Yeah, I think that's where it gets complex because most of our kids are what we kind of classify as like the category 4, which is like severe neurodisability. It's not cancer, it's not necessarily a progressive condition, and it's about comorbidities, which then just adds more and more meds and just really difficult to pick trajectory. And parents will just push and push and push until the end, really.
Yeah.
So that can be really tricky.
Yeah. Ruth, sorry, go ahead.
Hello. Yes, sorry, I don't think I have any answers, Christine. Other than, whether a guideline would encourage parents to, stop. But feeling like it's more of a clinical guidance rather than their decision. But I was going to ask something slightly different, which is about, I don't know if anyone's looked at this, but when a med is stopped, is that quite easy to translate into what the family have at home? So I know, like, if we work in a hospice setting, and so we're not actually the people providing the medication in the house, that goes via the GP, and it can be quite tricky to start a medication. So I wonder whether anyone's looked at that aspect of if you stop as a palliative care doctor stop a medication, does that mean the family are not getting fresh supplies into the home, or is that all, does it keep coming? Because the environmental impact could be lost if it's still being supplied by the pharmacy.
So certainly, say a ward patient will have on their discharge summary, the following drugs have been stopped, blah, 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 blah. And then, and highly likely if they're coming out of our hospice, we've done quite a bit of tinkering with their chart, their regular drugs. And so I'm hoping that the TTO list goes to the GP and they update their repeat prescription. Out in our community, we'll tell the GP that we have stopped this drug, please adjust the repeat prescription list. And on the whole, I think it does stop. And if you've done it in partnership with the patient and whoever they would like next to them, their family member, and they're in agreement, then they won't ask for more. So by hook by crook you get there.
Yeah. And there's an excellent project called Show Me Your Meds, which is from the southwest somewhere, isn't it? Looking at kind of going into people's homes and trying to figure this out. I would say as a community doctor, I see a lot of dossier boxes that have been issued that are out of date with what's been stopped, and actually that process doesn't work as smoothly. We'll come back to Kay, and then I might just show you the slides from Julia, who couldn't make it, and then we'll close. Kay, go for it.
So I would say most GPs are very keen to reduce the amount of medications that they're issuing, and a lot of the green team projects that we did up in Sheffield, it was GPs, changing all the inhalers so that they're not CFC driven, and a lot of GPs have been ahead of us within the hospital. Although I have personal experience of when my brother-in-law died, finding 34 unopened inhalers in his bathroom.
Wow.
34. So it doesn't get through. So, but letting people know as much as possible. Yeah.
Thank you. All right. I will just show you Julia's slides, just because she had a different perspective to offer, and I'm sorry she can't be with us. So you'll have to forgive me because obviously not my slides. So Julia's actually she's the clinical lead for the inpatient unit, and this is at Princess Alice, so not one of our pilot sites, but one of the topics that we've included in our award scheme, and that comes up a lot as a question, is in order to reduce waste and cost and save the planet, how do we reuse the medications that patients have? So this is their inpatient unit's approach to this. So I will have to whistle through it because obviously it's not mine, but clearly it starts with their medicines management policy. So they've managed to include a section on patients' own drugs. And I'm just looking at the timelines to see if I could get a clue as to how long it might have taken them to do that, but I imagine it's a bit of a process. And just looking at what she's put on that slide, I can see that the first step is needing to have the patient's consent to use those drugs and destroying those drugs if you don't have that. Interesting. So what do they do in preparation? So they wrote their policy. She's mentioned that they're not including controlled drugs in this, and I know she's put at the end of her presentation that that's proved more difficult. That actually they made some physical changes within the hospice to facilitate this. And then they had a new admissions procedure for patients' own drugs as well. So a form and then drug trolleys. And this is one reason I wanted to just share it with you, is that she's included, helpfully, just some examples of how they've changed their physical setup to make this possible. So they've got a drawer there, which we can't quite see, but it looks like it's different room numbers so that you can see which of the drugs belong to which patients. And then this is their working room for preparing medications. And then they've got slots in there for storing patients' own drugs injections, which is interesting, not something I was expecting to see included. And I can't see from that which injections. And my question to her would have been, would that have included anticipatory injections that somebody had in the community that were then coming in? So if it was, their glycopyrrolate or their haloperidol or something. And then they've got a record form, which goes through, and you can see there's things like risk assessments as well. And then looking at discharge as well. So then returning the patient-owned drugs. So another point that you're saving money and resources. And then, just a little note at the end to say the controlled drugs have proved much more complicated to do, as I'm sure you can imagine. So apologies that Julia couldn't join us, but I thought it was worth just sharing that. Mainly just to make the point that some places are successfully doing that. And I know for some hospices that's feels like a bit of an insurmountable challenge along the lines of, are we allowed, and what's the law, and is it possible? So someone's managing. I can see a couple of questions on that I'm probably hopelessly unable to answer, but we'll try. Steph, go for it. Oh, we can't hear you, no. Put it in the chat. I'll go to... Oh, I can hear you now, yeah.
Can you hear me now? Okay, I'll try and talk. It was just to say, if you can hear me, I used to work at St Raphael's Hospice, so another small hospice, and we're not linked to Princess Alice, but work closely together. We used to do this as well, so use the patient's own meds in the inpatient unit. And I think it was probably hard work at times for the pharmacist, but generally it felt like it worked really well. And with the patients who are coming in from home, we'd always say to the family member, bring in all the medicines with you. And it felt possible. It was a very small hospice and it felt possible, but it did feel like a lot less waste. I just wanted to say it's working there as well.
And Steph, maybe I can ask you then. Do you know if the anticipatory injections that someone had at home?
So I'm trying to remember. I think at St Raphael's, I think if the patient had come from hospital and come directly to our inpatient unit from hospital with all sealed anticipatories and controlled drugs, I think for the anticipatories we're able to use them. I have a feeling if they'd been at home, maybe there was an issue. So directly from hospital, okay, but maybe not from home, I think.
Okay. And I can see Karina smiling, so I'm wondering if she can help us with this.
Hi, yeah, this is very close to a project that I'm doing at the moment about meds waste in St Barnabas. So for us, actually, it's the exact opposite for anticipatory medications, is that we don't generally get anticipatory medications if people are transferred from the hospital. If they already have a CD1 just in case prescription at home, they won't have brought that in. But we, as policy, when people come from home, ask them to bring all of their meds. So we have all of their own prescriptions in lock boxes by the beds. We're quite lucky that we've got lock boxes for every patient. But that actually then makes it more difficult. And what I've found looking into medicines waste is that the nurses are much less likely to go and use the patient's own medicine for injectables that are in the pods next to the patient bed. So actually, I quite like the setup that they've got in the other hospice, whereby the injectables are actually in the drug room. So I just thought I'd comment on that.
Thank you, Karina. Yeah, I liked it too because it's right there. It did seem more integrated.
Yeah.
I'm aware of time. I'll keep going with questions because I can see there's interest, but I know a few people have said in the chat they have to go, and obviously that's fine. Go and get on with your day. I'll keep recording as well. Kate.
We looked at the costings of having a pharmacy technician to recycle patients' drugs, and they basically paid for a year's worth of themselves in about 3 months.
Wow.
So, I mean, that was a long time ago. So I had to, as lead clinician, I had to justify getting a pharmacy technician. And we just said, look at how much less things we're going to waste. I mean, there was the odd thing like, a box of Oriconazole, which is 800 quid at the time, or, but actually, if you have got lots and lots and lots of medicines that are 2 or 3 quid each, you can, and also we reuse their medications for TTOs as well. So, if they were coming in, if they've, I mean, we wouldn't use their injections if they came in. But if they were going back home and they had the pink card, the prescription that we use here, and their full box of medicines, because they didn't use anything at home, we would send them home with that. So we don't use the injections, but I'm sure it was a full-time pharmacy technician. It was a long time ago did the things, but the costings are incredible. And one of our pharmacists is doing it in the hospital. We are a very big hospital, but we are looking at saving between 80 and 100,000 a month for reusing patients' medications for TTOs.
Okay, that's fascinating, and I'm definitely emailing you after this for all of your insights. Thank you, Karina.
Sorry, just a quick one. I just wondered, I wanted to ask why the injectables weren't used, why the patient's injections weren't used, but tablets were, if they were patient-owned meds. What the reason was?
Because we've got stocks in the cupboard, and it was easier to keep an eye on CDs and things. It was just a bit too much of a faff, and yes, and actually, if they were coming into us with everything labelled, boxed up, full boxes, and it was easier just to use that for dispensing for discharge, essentially. Well, it's not D for D. It was patient's own medications. It just went into the TTO.
Yeah, that's good to know from my meds waste project point of view, because I've found I was looking into could we recycle blister packs first. So I thought I'll get a picture of all of the waste that we've got in the inpatient unit, everything that we destroy, and actually, rather than blister packs and tablets, the main thing we were destroying were ampoules. And because it was patient-owned prescription, and we couldn't use it again because it had that patient's name on the label, and we'd been using stock instead. So it's quite interesting to hear that's the way things are in terms of not using patients' own injectables.
Although I can see Saski's popped into the chat that they use patients' own injections and controlled drugs too. So people are finding ways to do this, and I'm really fascinated by the Princess Alice story of the logistics of how you set it up, probably being quite crucial. Like if it's harder to go and get the patient's own injection. Yeah. And Rita says we do too. Okay, it's gone past, but Melinda has her hand up, so we're going to carry on while you all slowly disappear. Go on for it.
Yeah. So this is around using just patient's own meds for that patient is not about reuse of medicines for other patients, is it? Yeah, because we use patient's own drugs and have done for a long time. Now, granted, our hospices are part of a trust, so it's slightly different because we're following their giant medicines management policy. But prior to that, before one of our hospices joined the trust, we still always use patient's own drugs. We would use the injections, but we tend not to use the CDs. And that's purely because, as Saskia said, they're in a different CD book. And what we find is everyone gets confused about which book they're written in. So we have green ones, green CD books award stock, yellow ones are patient's own CDs. It starts getting very messy. Everyone gets confused about which pages they're on. But we will use everything for discharge again. So when we're discharging someone home, if we can reuse that on a TTO, we will, even if that actually means relabeling it. So we can send things back to pharmacy to have them relabeled. Now, obviously, that's a little bit easier when you're on site, which means one of our hospices achieves that much more than the other because one's on site and one's off. But we will relabel things, especially if they're higher cost medicines, which we don't obviously have an awful lot of. But you do get the odd thing, as Kay mentioned, like you do get the odd blindingly expensive thing that you think, oh, blimey, yeah, let's not order any more of that unless we need to. So we will relabel, and we can relabel CDs as well. It's just that's more faffy because you've got to sign it out, send it with a porter back to pharmacy, sign it in, sign it back. So the chances of that getting just the governance of that drug isn't going to get lost. But the translation, it ends up coming back and going in the wrong CD register is actually the issue with that. Because it's then become a TTO rather than a patient's own, and it gets a bit confusing. But it can save a lot of money, and it's not just the cost saving thing, which is obviously very important, but it's about that safety of medicines and where they are. Because if we just constantly resupply more of these medicines, whether they're CDs or the other things that could potentially be misused or, you know, diverted, and everything requires then incineration to destroy when the patient has died or no longer needs the medicines. If we just constantly resupply, all we're doing is feeding into that. And then you get into the real kind of sticky wicket of, we've got these medicines in the cupboard and the patient doesn't need them anymore, but they're technically the patient's own medicines, and now we're discharging them, so we actually have to give them back to go home with, but they don't need them, and what are they going to do with them? Because they're not ours to keep at that point. So I think it's as much, and I think, yes, you need pharmacists and pharmacy technicians to do that. So, okay, I'm with you on that. And we do have techs and pharmacists covering the ward that support with those kind of activities. And they do pay for themselves, especially for technicians, they do pay for themselves very, very quickly because they can save a huge amount of money on doing that, and a lot of saving time wasted.
Yeah. And I think I would add, perhaps just to finish us off, that I'm sure you're all familiar with patients and families don't want there to be this huge waste. So one of the questions we get asked is, you know, surely you can use these medicines, surely you want them. It seems criminal to waste them. So yeah, there's that desire kind of driving us as well to use things effectively and to, yeah. Lovely. Well, we will finish there. Yes, I will share. What I'll do is I'll share the recording. So I've worked out how to upload that to YouTube because I'm very smart and learning all the time. So I will do that and then share the link. Kay, if you wouldn't mind putting your email address in the chat for me, we will get in touch. If anyone's got questions or wants specifically the slides, you can always email us at palcaresusnet@gmail.com, which is hopefully the email address you got the invite to this from, or send me a message on our network page and I can connect you if there's someone that was talking about something you're interested in. Yeah, please just drop us an email and we'll connect you up. Thank you all so much for sharing. That was really fascinating. I feel like we could keep talking for a long time, but we will stop. So lovely to see you all, and yeah, we'll be in touch soon.
Thanks very much.